Hello everyone, my name is Hoàng Bùi Hải. I am associate professor from Hanoi Medical University. I am the head of emergency department and intensive care unit. As you know, global burden disease estimated that injuries account for more than 80% of ill health in the world in 1990. This rate steadily increased between 1990 and 2017. Although the mortality decreased in most areas in the world, mortality rate in South Asia did not change. And why more than 90% of injuries-related deaths occur in low and middle income countries. Healthcare systems in these countries are least prepared to meet the challenge. This includes underdeveloped emergency system, trauma care, and rehabilitation system. Disabilities and death have a socio-economic impact, which in turn worsens the country's ability to prevent and treat injuries, forming a vicious cycle. We would like to present current situation in Vietnam and highlight the gap impacting on effective deliveries of trauma care. And Vietnam is, as you know, Vietnam is Southeast Asian countries of 98 million in population. The cost of healthcare per capita in Vietnam has increased over the last decade. However, it is still very low compared to other countries in the region. The number of calls to EMS Hanoi due to accidents and traffic accidents has increased over the last few years. Although the data is not available here, I would like to note that the majority of the deaths from accidents happen pre-hospital. There are about 8,000 deaths in Vietnam a year from injuries. The main type of accidents are traffic and construction accidents. They are very typical for the developing countries. The leading cause of the death from RTA is traumatic brain injury, accounting for 50% of death. Mortality rate in brain injury patients with pre-hospital coma is 70%. Taking traumatic brain injury as an example, majority trauma centers in Hanoi are provided with the most advanced equipment to monitor, to treat, and are able to perform a lot of different interventions. However, the challenge is getting patients to the hospital. This is the reality of the pre-hospital care in Vietnam. The picture, sorry. Okay. The picture on the left, the picture on the left side is the back of a 105-cent ambulance in Vietnam. As you can see, it's very close to no equipment that can meaningfully change patients' outcome. On the right side, the most popular ways to the emergency department, including motorbike, piggybacking, while the ambulance is stuck in traffic. Although the government released a new regulation in 2008 requesting for each province in Vietnam to have its own 105 EMS center, the reality is most do not have one. Some have 105 centers, but not the staff required to run it. And Hanoi, which is the capital city of Vietnam, with 8 million in population, has only 20 ambulance teams. It's consistent of 1 doctor, 1 nurse, and 1 driver. There is nowhere near enough compared to requirements set out by WHO, smaller cities in Vietnam are even more short compared to Hanoi. And even when there are EMS centers, they are not well staffed, not well equipped. The PET center is not centralized, and there are 3 different sources of course. There is no communications between one of 5 centers and hospitals. And having identified these challenges, here as a way to improve the quality of managing injuries in a developing country like Vietnam, the government has put preventive measures to reduce RTA, such as reconfiguring traffic flow. This should continue. We urgently need to strengthen the deliveries of treatment to the patients even before they reach the hospital if they want to make a difference to their outcome. Therefore, it is crucial to invest in pre-hospital medicine. This includes investing in properly equipped EMS centers and transportation service, and establishing the link between EMS centers and hospitals. Last but not least, we need to continue to focus on training and research. Everything starts with identifying gaps in the healthcare and the challenge that we are facing from there. Planning quality improvement projects and implementing this. For example, we are perhaps one of the first people in the country to get the attention about the state of emergency service in Hanoi and Vietnam. We have since established a training program to healthcare professionals and as lay people to improve pre-hospital care in Vietnam. We are also hoping to develop our own model of emergency service that is tailored to developing countries like Vietnam, which is our challenge. We look to platforms like this to hear more about from other countries' experience and together share ideas about how we can move forward. To conclude, as a severe trauma requiring intensive care is the leading cause of disabilities and death in developing countries, including Vietnam. The main challenge remains getting patients to the hospitals, ED major trauma centers. Pre-hospital care, including first aid, EMS, dispatch centers, proper triage, and transportation to the appropriate hospitals has not been paid attention to and developed properly. There is a need to drive research and training to find solutions to change and improve the abilities to effectively manage patients with severe trauma. Thank you for the attention.